I think we'll go through, well, I know we'll go through. I'm going to do the roll call introduction of everyone. So when I call out your name, just please introduce yourself and, along with saying present or I or whatever here, just give a brief little introduction of yourself. So I'll start with Senator Eckert.
Hi, so this is Gabrielle, her chief of staff. Senator Eckert just got out of committee, so she's going to be on in like less than 5 minutes. So she'll be back soon.
All right, we'll mark her as here. I think Senator Hester is probably in the same situation, but I'll call her name out anyway.
Hi, Lieutenant Governor. This is Nathan, Senator Hester's chief of staff. She is in the middle of EHE, and they're not looking to be out for a little bit. So I may end up giving the subcommittee report today.
All right, thank you. Okay, Delegate Kelly. This is the middle of session, so. Delegate Young. Okay. Richard Abbott.
I am here, Director of Juvenile Family Services for the Maryland Judiciary, and I represent the Maryland Judiciary on the commission.
Okay. All right. Thank you. I imagine Dennis Schrader is not here.
He's not. This is Trisha Roddy, Assistant Medicaid
Hi,
Director,
Trisha.
and I'm here.
Okay. I think maybe we should put Trisha's name here instead of Dennis, because Dennis is off doing COVID stuff. Okay. Dr. Aaliyah Jones.
Hi, good evening.
Good evening or afternoon or whatever we are.
I know, right?
Yeah. Okay. Lieutenant Colonel Butler.
Good afternoon, Lieutenant Colonel Roland Butler, Chief of the Maryland State Police Field Operations Bureau.
Thank you, sir. Dr. Boneski.
Good afternoon, Lieutenant Governor. I'm the Acting Director of Mental Health for the Department of Public Safety and Correctional Services.
Okay. For some reason, your volume was down. I could still hear you, but I had to turn my volume up a little bit.
Okay, I'll turn mine up. Thank you.
Oh, there you go. All right, thank you. Tiffany Rexroad.
Yes, good afternoon. Representing the Department of Human Services as the Acting Assistant Deputy Secretary of Programs.
Okay, thank you. Commissioner Bahrain.
Hi, how are you, Lieutenant Governor? Kathleen Bahrain, Maryland Insurance Commissioner. Happy to be here.
Great to have you. Director Steve Hsu.
Good afternoon, Lieutenant Governor. Steve Hsu, Executive Director of the Opioid Operational Command Center.
Thank you. Christian Mealy.
Good afternoon, Lieutenant Governor. Christian Mealy, MDOD, Deputy Secretary, moonlighting as the COVID staffing czar, whatever they call me these days.
Whatever they throw on you next. Okay, thank you. Mary Gable. Okay, maybe Mary.
I am here. I'm sorry, Mary. Yes. Good afternoon, Lieutenant Governor, with the Maryland State Department of Education, Division of Student Services and Policy. Thank you.
Okay, and you're hiding behind the Title 13A of the Board of Education regulations, it looks like.
Oh, am I?
Yeah.
You know what? My camera must be backwards. So I'm
Mine
looking at you.
Mine has done that.
So
I've done that several times on my tablet. The
yeah,
camera's
that's
on
where
both
I am.
sides. Okay.
I'll try to fix that.
You could be behind the books. That's okay. Barbara Allen. I thought I saw Barbara, but maybe she's not.
I'm trying to unmute.
Oh, there you are. Okay.
I am here. Yes, indeed. Barbara Allen, I am co-chair of the Behavioral Health Advisory Council for Maryland. And among other things, I serve as the chair of the Howard County Opioid Crisis Community Council. Glad to see all the faces.
Good to see you. Pat Metashevsky.
Hi, Lieutenant Governor.
Hello.
I I am a family advocate with lived experience and a registered nurse.
Okay. Dr. Triparani.
Hi, Lieutenant Governor. Good afternoon, everyone. Glad to be here. I am an associate medical director with the Kaiser Permanente Mid-Atlantic States.
Good to see you. Carrie Cho.
Hello, sir, and everyone. I am Carrie Cho. I'm the president and CEO of Cornerstone Montgomery, a behavioral health provider in Montgomery County. Glad to be here.
Glad to have you. Serena Eckwood.
Good afternoon, everyone. Hello, sir. Nice to see you again.
Good to see you.
Serena Eckwood with NAMI Prince George's County. I'm on the board and a volunteer and also a family advocate.
Very good. And Kimberly Watts.
Hi, I'm Kimberly Watts. I am an attorney with the Public Defender's Office. I'm in our Forensic Mental Health Division.
Okay, very good. I'm going to ask now if everyone has had a chance to review the minutes and if there are any questions, suggested changes on the minutes. Do we have a motion to approve the minutes?
So moved.
I'll second.
All right, all in favor, say aye.
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 Any opposed? Okay, then the minutes have been approved. I'm going to go to the subcommittee updates, and we can start with Steve Shue and the Crisis Services.
Thank you. Good afternoon, everyone, and thank you, Lieutenant Governor, for your ongoing efforts to support the work of this commission. I'm very glad to be here today to give you an update on the work of the Crisis Services Subcommittee. The subcommittee met last week on March 3rd. During our meeting, we presented an action plan for advancing the recommendations we submitted to the larger commission. We wanted to identify specific steps to ensure that we continue to make progress in achieving our stated goals for enhancing the crisis services delivery system. We also heard 3 special presentations. First, we had an update on crisis-related bills that are being considered during this year's session of the General Assembly. Next, we heard from the Behavioral Health Administration and Every Mind Montgomery County on the state's plans to migrate to the National Suicide Hotline 988. BHA is convening a statewide coalition to assist with the implementation of 988 as the state's new suicide hotline, which will become effective in 2022. This coalition will begin meeting in April. Lastly, we heard from Dr. Maria Radowski-Stanko from BHA on the administration's plans to expand crisis services for youth and adolescents. We were especially pleased to hear about the additional resources that have been dedicated to expanding the youth and adolescent crisis services system, as we often hear about the needs of this population. In other related business, we're pleased that BHA has convened the Crisis Services Advisory Work Group to identify ways to expand Maryland's crisis services delivery system, utilizing best practices outlined in the Crisis Now model and SAMHSA's Best Practices Guide. We were able to provide an update on the work of the MBH Commission's Crisis Services Subcommittee during the first meeting, and will continue to participate in BHA's meetings on an ongoing basis. We look forward to partnering closely with them to ensure that crisis services are available to any Marylander in need. That concludes the update. Our next meeting will be on Wednesday, May 5th at 10 a.m. And thank you again for your support. Back to you, Lieutenant Governor. You're on mute, Lieutenant Governor.
Sorry about that. Youth and families. I put it on mute because I was shuffling papers. So.
Thank you, Lieutenant Governor, members of the commission. The Youth and Family Subcommittee met yesterday, March the 8th. During this meeting, NAMI Maryland, National Alliance on Mental Illness, presented on assisted outpatient treatment. Their presentation included considerations of appropriate uses, successful components, and challenges. With respect to the ongoing evaluation of the danger standard, NAMI Maryland agrees that it is worthy of continued discussion. That discussion has continued within the work group and among the Behavioral Health Administration. The work group is considering language proposals related to the danger standard and plan to issue a questionnaire. Additionally, the Youth and Family Subcommittee also received an update that the School Psychologists Association met with Maryland Medicaid to discuss a path forward in reimbursement for school psychologists. Thank you.
Okay, very good. The Finance and Funding Subcommittee.
Hi, Tricia, do you want to go first or would you like me to?
Go ahead.
Okay.
That's fine.
So the MIA with respect to the private insurance market has been busy since session started. We've reconvened our internal work groups for MAPIA, the MAPIA reporting bill and the network adequacy regulations, and we will be holding our next public meetings for each of those groups immediately after session concludes, and you'll see notices coming out shortly with those dates. With respect to
System Fair Work Group, which met in
In 2020, co-chairs Dr. Linda Beneski and Senator Hester, in collaboration with Director Shu, obtained funding from the Substance Abuse and Mental Health Administration, SAMHSA, to host the first Maryland State Summit on Behavioral Health in the Justice System. That report has been sent back to us and is now available on the Commission's website. And SAMHSA has developed 13 recommendations to strengthen services, close gaps, and create a continuum of care within the state of Maryland. Just to briefly walk you through the 13 recommendations that are there, and there's quite a lot of detail there. So if you haven't read through it, I would highly recommend it. But those summit recommendations include formalizing a statewide planning body to address the needs of justice-involved persons with mental or substance abuse disorders, developing a mental health criminal justice center of excellence or expanded evaluation system to track program development, centralize resources, and provide technical assistance, broaden and formalize county-level criminal justice / behavioral health planning committees, integrate Maryland's behavioral health and criminal justice initiatives with related state health initiatives, continue to expand the crisis care and continuum, and expand strategies to reduce law enforcement's need to respond to crisis events, and provide adequate clinical support when law enforcement does respond, develop more formal and coordinated diversion strategies for arraignment diversion and pretrial diversion, which are intercepts 2 and 3 respectively, develop a formal and coordinated screening process of jail booking or as early as possible upon entry into jail, to identify mental illness and behavioral health needs, develop a more formal approach at the local and state level to expand housing options for justice-involved individuals, expand screening for veterans across intercepts, allow early diversion and misdemeanor alternatives for veterans, increase access to transportation, expand the use of technology across the intercepts, expand data-driven strategies across the intercepts, and then expand the utilization of peer support across the intercepts. So what I've just read to you is quite a long and ambitious list of recommendations from our folks over at SAMHSA. We've decided to act on a couple of those things this session in the scope of Senate Bill 857 and House Bill 1280, cross-filed by Delegate Penny-Melnick. And in that legislation, we'll be creating a Maryland Behavioral Health and Public Safety Center of Excellence. The Center of Excellence will serve as a central repository of information for programs related to behavioral health, criminal justice, and public safety in the state of Maryland. They will also work to provide technical assistance to localities, foster collaboration between jurisdictions, as well as the state behavioral health and justice systems, and develop statewide models for programs that would increase treatment and decrease incarceration for justice-involved individuals' behavioral health illnesses. part of this idea is that having an implementation body that is accountable for these goals and to carry on the work of implementing the sequential intercept model will make sure those recommendations really reach people across the state. We are also requiring that local jurisdictions engage in the planning of the behavioral health systems in 2-year plans so that they would formalize and coordinate their own bodies through the process of engaging in that planning exercise. And furthermore, the center would be charged with carrying on the second half of the SAMHSA grant that was secured last year to facilitate the train the trainer events along with our folks over at SAMHSA, for which the funding is already secured. I just gave you a whirlwind tour of a lot of stuff that's happening during the General Assembly session. I'm happy to follow up with anyone and circulate the report through the appropriate staff as necessary. And with that, I will hand it over to our co-chair, Dr. Linda Beneski, to add anything else. Did I miss anything?
Just our next subcommittee meeting will be March 24th at 1 o'clock to 2:30. You did a great job.
Okay. One of the things I did, I think my staff sent out, there was an article about mental health courts. And I know in Maryland we have, in some of our counties, we have drug courts. It was an interesting article, kind of looking at both sides of the issue, the positives and potential negatives associated with it. Maybe at a later time we can talk about it. And I think Baltimore City may have a mental health court, but I'm not sure about that.
Yes, they
maybe
do.
Someone can correct me. Okay,
Yes, they do.
So does Montgomery County.
Okay, all right. Any feelings with regard to whether it's been a positive or how things could be improved? Anyone?
I think it's been fairly successful in Montgomery County. We at Cornerstone Montgomery, we work with quite a few of the folks who are in there, and it has its challenges. People have to be willing to participate, and sometimes that's a challenge, but I do think it has been helpful in keeping people out of jail and in treatment in the community.
Yeah, I would agree. I think that mental health courts have been helpful. In some instances, if it's too much pressure on fragile people to do a lot that they have a hard time doing, and that creates unnecessary pressure. So that's the downside of it. But on the positive side, for probably the vast majority of people, it's a helpful resource.
I know on the drug court side, you can have some, disincentives in a sense that if a person is, let's say, arrested for a minor offense and their time is, 3 months in the local jail, and the drug court, says, hey, we can wipe that out if you do this, 1 year or 18-month program. Sometimes the person says, I'll do the 2 months versus 2 to 3 months versus, be essentially under a court order for 18 months. So I know that's popped up from time to time with the drug courts. And again, it all comes down to a person wanting to participate. And I guess it's the same as you just were mentioning with the mental health courts as well, that the person has to see value in it.
Lieutenant Governor, Senator Kurtz here.
Oh, welcome.
Hey, thank you very much. I'd just like to say I was around when we first started the drug courts, believe it or not. And Delegate Pauline Menace and several people advocated. We went to Baltimore City at that time and learned all about drug courts. I was very impressed, and then worked with the judiciary to expand them around the state. And since that time, they've merged into a variety of specialty courts, mental health courts, drug courts for both teens and adults. Adults seem to have a better outcome, and that's been validated when we've done the various legislative analysis through the years. And then Veterans Court, mental health courts. I know the judges in Talbot County have been very supportive of these programs because they're able to bring all the service providers together and wrap those services. It's almost like the 2-gen through the courts.
Yeah. Mm-hmm.
Bringing everybody together. It's a supportive environment, can be very therapeutic, and it provides that network to be able to what I call support people so they can move through and gain kind of re-entry and reprocess, things that have gone wrong in the past. So we do a lot of being out and around at those graduations on the Eastern Shore, both in Wacomico, Talbot, particularly Dorchester uses it to a certain extent as well.
Okay. Well, it sounds like, as we've talked about assisted outpatient treatment, this is kind of really kind of addresses that, tries to serve some of that purpose. And maybe when we listen to the presentation from the Treatment Advocacy Center, you can mention, any feelings with regard to mental health courts and whether there's, what type of benefit and how that may interact with assisted outpatient treatment, or if you even need it, if you have a robust drug court. Because I guess even with outpatient treatment, typically it's because they've come before the courts some type of way, or they've been in the emergency rooms over and over and over again. But typically it's some type of interaction with law enforcement.
Yeah,
So,
and it's labor intensive. I think anytime we wrap services around those in crisis who've been without medication for a long time, or for those who've been incarcerated in and out for a long time, it's labor intensive and it's front loaded, one at a time, one person at a time, one soul at a time. So it's really complex, but it does work most of the time.
well, I guess it's a good time to turn to Brian Stinton, and I think I'm pronouncing your name correctly, Brian.
Close enough.
Okay.
Yeah, that's fine. Thank you so much. Great to be with you all. Thank you, Lieutenant Governor. I'm going to spend a few minutes today to talk about the need for a danger standard in Maryland law. Not so much on the topic of AOT, but I will just say quickly to kind of close the loop on the discussion just now, that mental health courts and assisted outpatient treatment programs really work very much hand in hand. Both are needed. Neither obviates the need for the other. The essential difference is that an AOT program is civil, right? It's taking place in the civil system. It doesn't require a pending criminal charge at the price of admission. So even though many of the people in AOT programs have criminal histories, we don't have to wait for that to actually be the situation, the bind that the person is in before we can intervene and get them help. But just to turn then to the topic today of the need for defining danger in the Maryland law. I should just say I'm an attorney and the policy director for a group called the Treatment Advocacy Center that works around the country to improve state mental health laws. We're based in the DC area in Arlington, Virginia. And of course, it's always gratifying to get an opportunity to do the work that we do in our own backyard in a state where a good chunk of our staff lives. And we are comprised as an organization mostly of people who have a loved one with severe mental illness. So these issues are very personal for us. If I could just share my screen, I'm going to show a few slides. Hopefully this works. Just get into slideshow mode. Okay. You've got me on the screen, right? Great. So the need for a danger standard really stems from the fact that there are many individuals in our communities that have severe mental illness, are in desperate need of hospital treatment for that because they're in a state of crisis and are unable to engage with that treatment on a voluntary basis. You know, we should start out by making clear that nobody likes civil commitment. It is a last resort. We can, I think, universally agree that it is always preferable to get somebody to engage on a voluntary basis. But we also have to be realistic and acknowledge that's not always going to be in the cards for everyone who finds themselves in a psychiatric crisis. And again, we're talking about these folks who are caught in the revolving door, who cycle in and out of treatment repeatedly, who often wind up in jails or prisons because they commit offenses they would never have gotten involved with had they been engaged with treatment in the community. And the key to stopping this cycle is to get people engaged with treatment. And why this is a struggle for so many people with severe mental illness is a complex question. I don't mean to oversimplify it, but I think one important factor that we really ignore at our peril is a symptom of brain dysfunction known as anasagnosia. Again, not the only reason that some people have difficulty engaging with treatment, but it's a big part of the explanation as to why we're always going to have a need for involuntary treatment as part of our mental health response system. However great a system of community-based care we're ever able to build, there's going to be folks who don't come into it voluntarily. And this brain syndrome is essentially about lack of insight. It's about a person with mental illness not recognizing that they have an illness at all. And sometimes this is casually referred to as denial. Someone will say, you know, my son is in denial. He doesn't want to get help for his mental illness. I think we should all understand the difference, right? Denial is a universal human defense mechanism. It's something we've all practiced at one time or another in our lives when there's a painful truth that we actually do know. We're aware of it deep down. We may need some help coaxing it to the surface and recognizing it and confronting it. That's not what's going on with people with anasagnosia. This is about dysfunction of the brain. The person who lacks insight due to anasagnosia does not know the truth deep down. They are certain to their core that the suggestion that they have a mental illness is absurd. And as painfully obvious as their crisis may be to everybody around them, they simply can't see it. And here we're looking at 2 brain scans of individuals with schizophrenia, one individual who has insight and the other who does not. And at this moment, these individuals are being asked to perform a self-reflective activity. And you can actually see brain activity happening in the individual with insight that just isn't not happening for the other. So this is no more in a person's control than is any dysfunction of any organ of the body any of us might experience. And it's not a reason to get frustrated with the person. From their point of view, it's perfectly rational and logical and sensible to want to disengage with treatment. The question is, do we have the laws that allow us to take action to overcome this when the person can't do that for themselves? We really don't have the luxury of waiting around for somebody in a crisis to recognize their own need and figure things out. We have so much research that tells us that time is of the essence to get somebody help when they are in this condition. That the longer somebody remains in a state of untreated psychosis, the lower their prospects for recovery, the greater the risk that they're going to experience damage to their brain, actual physical harm to their brain. We know that waiting around for a person to prove that they are dangerous often leads to them committing a criminal act that now has them in the clutches of the criminal justice system, which is something none of us want to see. So we don't have the luxury of waiting for the person to figure it out or for something so terrible to happen that they wind up in the hospital by default. We have to have a law that makes it possible for us to take action when a person is in need. And the tool we have at our disposal to make that happen is our civil commitment law. Like every state in Maryland has a law that allows you to respond to a crisis. And as in every state, the key criterion in that statute is that you have to find the person is a danger to themselves or others. Every state has that as the ultimate crux of the inquiry for a court or for a clinician who's evaluating a person. What varies from state to state is what exactly it means to be a danger to yourself or others, or more specifically, what it means to be a danger to yourself, right? Because there is fairly universal understanding of what it means to be dangerous to other people. But dangerous to self is something we ought to take a minute to consider how broadly or how narrowly that ought to be defined. And of course, the other thing that may vary among the state laws is how imminent that danger must be before we're allowed to act upon it. So just to look at the Maryland civil commitment criteria in this context, there are 5 things that must be found to place somebody under civil commitment in Maryland. The one I have in yellow is the one that tends to be the most controversial and the thing that courts and clinicians grapple with the most when determining whether it's necessary to civilly commit somebody, whether that person presents a danger to the life and safety of themselves or someone else. What makes Maryland unique, and not quite unique, but one of 5 states, is that the law provides no guidance on exactly what that means to be a danger to the life or safety of yourself or someone else. There's only 4 other states that provide no statutory guidance on what that means. And that leaves the meaning of the term really in the eye of the beholder. All the people who have to interpret this law throughout the system are basically left to decide for themselves what it means to be a danger to yourself or others. And it should be of no surprise that because of pressures on the system, the fact that there are shortages of beds, and so many of our beds are occupied by people coming in through the forensic door, that not having the term defined tends to lead to an extremely narrow definition, the narrowest possible interpretation of danger to self or others, which tends to boil down to the person's risk of committing violence, committing suicide, or engaging in some shockingly risky behavior such as walking into traffic. But if we are going to have a truly compassionate and responsive law, we have to think beyond those situations in defining danger to self. If you look at the way this has been defined in the various states that have this statutory guidance, you find that there is also a recognition that a person who is gravely disabled, that is unable to meet their basic survival needs for food, clothing, shelter, medical care, etc., is also in a very real sense a danger to themselves. We see that in the law of all 45 states that provide statutory guidance on this question. And beyond that, half the states roughly also go a step further and recognize that psychiatric deterioration, the risk of it, is also a form of danger to self. That a person's inability to prevent harm to their brain that will result from continuing non-treatment is also a form of danger that we ought to be able to protect an individual from. Just to look quickly at some state laws that incorporate this, here you see the grave disability standard in Michigan. It says the person's unable to attend to their basic physical needs, such as food, clothing, shelter, etc., in order to avoid serious harm, and has demonstrated that inability by actually failing to attend to those basic physical needs. Here we see a psychiatric deterioration standard in the law of Illinois, where the law defines the person subject to commitment first as someone who is physically dangerous, second as someone who's gravely disabled, and third, on a 3-point test here, the person is refusing treatment or not adhering adequately to prescribed treatment. They are unable to understand their need for treatment, and if they are not treated on an inpatient basis, are reasonably expected to suffer mental, emotional deterioration, and after such deterioration, to become physically dangerous to self or others or gravely disabled. And these are basically the standards we are trying to incorporate into Maryland law by once and for all defining danger. We have a bill pending in the legislature now. We're going to have a hearing on it, I believe, next week, sponsored by Senator Reedy and Delegate Kipke, that would define danger to the life of safety of the individual or of others. This term that appears currently in the Maryland law without a definition will now mean one of 3 possible things: that the person is going to cause bodily harm to themselves or someone else, that they are unable to provide for their basic needs, or that they are at risk of suffering substantial psychiatric deterioration, provided that is a person who can't make themselves a rational and informed decision as to whether to submit to treatment. We feel it's very important that this standard be enshrined in state law. I know there's been talk about maybe doing this in the form of a regulation instead of a law. We strongly urge that this be done legislatively. For one thing, because this standard has to be interpreted well beyond the health system, the mental health care system. These standards have to be understood by folks in law enforcement, by courts, by families deciding whether they're even eligible to get help for a loved one. Most of those individuals are never going to see a health regulation. The prominence of the law is a really important reason why we need this, I think, done legislatively. And secondly, it's just the importance of having this become a permanent part, a fixture of the public mental health system in the state. You know, regulations are so easily amended or rescinded. Families who rely on this law have good reason to want this to be something fixed that they can count on and that doesn't seem to be going away anytime soon. And so for that reason as well, we really urge solving this problem through legislation. So that's just a quick walk through why we feel the need for this is so great and what we're hoping to see passed this year. Happy to answer any questions, and I have my contact information on the final slide. Would love to engage with any or all of you further.
Any questions, Pat? Will you?
Yes, thank you, Mr. Stetton. I was just wondering, is there any data that you're seeing for those individuals with mental illness and they also have a substance use disorder? When you're talking about, even on the substance use disorder side, they can have a substance-induced psychosis that might represent itself in a similar way. And they also have this deterioration. So I know the focus here seems to be on mental illness. What about those with co-occurring or even substance use disorders?
Yeah, so there are states that have a separate process for civil commitment for substance abuse. I think the data is probably a lot less compelling that that's actually effective in terms of making a significant intervention in a person's life in the way civil commitment for mental illness is. And as you say, there are many people who have both conditions at once. In Maryland, civil commitment is only possible where you have a diagnosed mental illness. So in those 5 criteria that I had in one of my slides, and we focused on the one that says a person has to be a danger to themselves or others, there's another criterion on that list, the first one, that says that it's got to be established that the person has a diagnosed mental illness. If they do, and they also happen to have a substance abuse disorder, they're potentially eligible for civil commitment if they meet the rest of those criteria. But, you know, there's no question, the challenge of recovery is greater for those who are newly diagnosed, and there needs to be kind of a holistic approach when you have somebody civilly committed. And beyond that, when you have them back out in the community receiving outpatient care, you've got to address both issues at once, or you know, the person is not likely to achieve recovery of either. So,
do we have any prevalence as to, you know, even if this is just refers to mental illness, of those who have a co-occurring disorder, do we know what the prevalence of that is? Do we see a lot of it?
in terms of how the prevalence of co-occurring disorders among people with serious mental illness?
Yes.
Yeah, it's quite high. I unfortunately don't have a statistic at the top of my head. There may be somebody else on the commission who can jump in and help me here, but it's well over half. I mean, it's a significant percentage of folks.
We see about 70. I'm sorry, Lieutenant Governor. We see about 70% in the prison system.
Mm-hmm.
Yeah, I was just going to say, and I don't have the data, but I know anecdotally that there's a large percentage, and I know hearing from the prison system that a large percentage of their people who have mental health disorders also have the co-occurring substance use disorder. So I would imagine if you've seen it in that setting, you're probably seeing it in others. I mean, we heard testimony last week about an individual who their child was diagnosed with bipolar, and they subsequently then started using illicit drugs that we know that it exacerbates the problem. So it's either a person is trying to self-medicate, or they may have started with the drugs and it induced psychosis.
To me, there doesn't seem to be an integration here. We have a mental health court and a substance use court, and even the treatment we give now, we know that our providers are seeing some of these people, and we're not even, looking at what the prevalence of that is. And then what do we need to do to change the system to be more welcoming to people with both disorders? I know even from a financial reimbursement from right now, that the way that we reimburse also fragments how we treat. And so it's not just the clinical, but we have to work together with the financial piece so that we have a system that, you know, is more welcoming, I guess that's the word, to this. So I don't know. I just think it's just so, we were just so far apart. I mean, we even have people who use substances. I mean, you look at schizophrenia with substance use, it can be very dangerous.
Oh, yeah,
So,
yeah.
yeah. So
Right.
I don't know. I just think that's an important area, you know, to look at more integration and less fragmentation.
Yeah. Well, I mean, that's we've, you know, generally talked about that whole, even that breakdown between what people can consider, you know, physical health versus quote unquote behavioral health.
Right.
And going back to Senator Ecker's talking about, you know, kind of really a holistic approach, what she called 2Gen, which 2Gen is much more on the social services side, but it's bringing all those factors together because, you know, with all of this, housing is also another issue that comes into play. So it's, you know, as she was saying, there's so many, when you have, like she said, either the drug court or mental health court, is trying to bring all these factors together because, like you said, that person may have an underlying mental health issue or an underlying substance use disorder issue, combination of the two, and it's being able to break down the barriers to, you know, maybe it's one court, it means, you know, bringing in all those resources. But, you know, it's the same for, you know, a doctor. We're asking now primary care doctors to ask about substance use disorder, to ask about mental health issues. Now, they may not be experts in any one of them, but then where do they go from there? Do they go to a treatment person that it's only substance use disorder or mental health? And so it's going to be, you know, I think we're going to have a lot of new, you know, maybe new specialties coming online.
There are models that do both. I mean, Cornerstone Montgomery has been following the evidence-based practice, which is called ITCOD, Integrated Treatment for Co-occurring Disorders, for 15 years. And we've done it under our mental health umbrella. We are not certified in the state as a substance use provider at this point. We've been doing it under our mental health umbrella. And that there are principles to that evidence-based practice which say you need to assume that everyone who comes to you has co-occurring disorders. You need to expect it. And that all the research shows that people do better when you treat both disorders at the same time with the same team, and you don't call one diagnosis primary or not. And that's one of the issues, of course, with insurance. And because
I was going to say, that's the insurance issue right there.
Yes. Yep. Yes. And because we're only certified as mental health, we have to have a primary mental health diagnosis. We're going to try and change that in the next couple of years for ourselves and get certified as both. But it is an issue. But absolutely, all of our staff are trained on treating both disorders at the same time, that one is not legitimately primary over the other. And that is absolutely, it used to be 20 years ago, if someone drank in our residential program, we would discharge them. We would say, you need to go take care of that problem first and then come back and we'll help you with the
come back.
Yeah.
Right. And of course, you know, that was ridiculous. We realized that was ridiculous. So we changed 15 years ago, but it is an ongoing challenge. And I agree with the courts being separate. I think mental health, I'm sure both courts deal with people with both disorders. There's no way of getting around it. But it is a challenge. Absolutely.
Right.
Right. But there are across the continuum, you know, all throughout Maryland, our treatment providers. You, Carrie, you happen to be co-occurring capable, and I'm very aware of that. But we don't require that all of our providers be co-occurring capable, you know, because then we have that gap.
I think, Richard, you were going to say something?
I was just going to add that, yeah, the treatment courts deal with co-occurring in a majority of the cases. So just because one's called mental health court, one's called drug court, and again, that's just the way they were developed. over the years, but they realized, again, probably in the last few years that, yeah, there's co-occurring in a majority of the cases that come through.
Okay, I think Kimberly Watts had something you were gonna.
I did, thanks. I had a question for Mr. Stinton, two of them actually.
Sure.
My first one is about where the information about narrow interpretation comes from. My office represents people in involuntary commitment hearings, and I know last year we had probably more than 6,000 of them, but only 230 of our clients were actually released, and they weren't all found dangerous. Some of them were released for other reasons. My second question is, how do the proposed bills distinguish between somebody with, I know I'm going to bungle it, Anasagnosia.
Anasagnosia, yep.
Thank you. And somebody who's just in denial? How do the bills distinguish between those two?
Sure. Well, I'll take the first question first. And I think it's important to keep in mind that the point at which your office as public defenders are involved in the cases, that is when you have an actual case up for an administrative hearing before an administrative law judge, is pretty far down the chain in the process for what it takes to get somebody civilly committed. So that when you have that narrow interpretation that's happening at earlier points in the process, that is when police officers are making decisions about what they're observing in the community that constitutes dangerousness to self or others, when 911 operators are taking calls from people who are calling about family members and describing situations and trying to assess whether or not this constitutes a situation that represents danger to self or others. When clinicians are evaluating people who have been brought into emergency rooms and making determinations about whether to go forward and seek civil commitment to the point where your office would become involved. At all those points in the process, a narrow interpretation, which I'll explain why I think it is fairly pervasive, is preventing those cases from even getting to the point where your office is involved. So I think you're seeing only a sliver of the situation when you focus on people who are actually appearing in court. As to why we have a strong sense that there is a narrow interpretation that's taking place at all those other points in the process, it's because we're hearing it all the time from families. We had the last time we had this bill under consideration, we had a long chain of individuals who came and told really horrible, tragic stories about how they were unable to get help for their loved one simply because they were told they are not dangerous to themselves enough yet. Let us know when they are. Let us know when they're acting out violently or abusively or doing some harm to themselves, and maybe we can get some help to them. And that waiting around often led to the person winding up in the criminal justice system. So I have good reason to think that that's happening all the time. There are probably other members of the commission who can speak to that as well. To take your second question as to how the law incorporates the presence of anasagnosia or not, I didn't mean to suggest that anasagnosia is in any way part of the legal determination that's made here. I brought it up only as an explanation as to why I think we're never going to get to a point where our system of voluntary care is so good that everybody is going to come flocking into it. But there's nothing in the law that would distinguish on the basis of whether someone has anasagnosia. If they are a danger to themselves or others because they are violent or suicidal, or because they're gravely disabled, or because they can't protect themselves from psychiatric deterioration, they would be eligible under this danger standard, whether or not they're actually experiencing anasagnosia, or if there's some other explanation for why they're not seeking care.
Senator Ecker, you had a question?
I did real quickly. Thank you very much, Mr. Stettin. I've been struggling with this since 1970. We've been dealing with this. In fact, I have a case that I've been working with this week where a lady has been totally out of control, unable to manage herself, and we're trying to get her surrounded by folks to be able to make that improvement. But my question is, on all of the other states where they have that standard of dangerousness, what is their, I don't know how to say it, success rate? What is the outcome? How have they found that changed their system in getting people into care, and has it been effective? If you could
thank you.
To us even after this meeting, I think that would be great, because I think the proof is with the outcome. Thank you.
Sure. And I can share some data with you, and I'd be happy to do that. I think what we find, which may be surprising to some, is that having a civil commitment standard that makes it that allows action at a sooner point in a person's decompensation doesn't actually lead to more people winding up in the hospital. You know, these horror stories that we hear and the folks who came and testified about this bill when we had it up a few years ago, all of them will tell you their loved one eventually did wind up in the hospital. So what we're trying to facilitate here is earlier intervention. If you can get to a person at a point where they are less acutely ill, you can get them out of the hospital sooner. They need to spend less time there to get back home. The other thing is you're avoiding them winding up in the criminal justice system, in which case they wind up hospitalized as a forensic patient because there's need to restore them to competency, right? Which can take a very long time and often ends in frustration. The person gets released to repeat that cycle again. So by having a civil commitment law that makes clear that danger means more than just being violent or suicidal, what you will see happen, other states' experience suggests, is not that more people come into the system, the same people come in sooner. And look, there's a lot of reasons why some of those states aren't doing a better job than Maryland in getting people timely treatment. You know, a lot of them have shortages of beds. And I don't mean to suggest that making this one change is going to, in and of itself, magically improve the public mental health system. It's a necessary but not entirely sufficient step towards getting to that better place.
Thank you. Thank you.
Sure. Thank you.
Any additional questions?
I would like to thank you, Mr. Stratton, for doing such an important work. The changes in the civil commitment law in the state of Maryland was long overdue, and I'm glad that you are introducing these amendments, which will go a long way in helping members who are not acknowledging the disease process that they have and are going through this vicious cycle of revolving door and eventually ending up being either homeless or going through the criminal justice system rather than really getting the help at the right time. I'm hoping this will have a very positive impact, not by increasing the hospitalizations, but really decreasing this revolving door admissions into the hospital all the time.
Right.
And having mentally ill patients getting into the criminal justice system and becoming homeless.
Right.
Thank you so much.
You know, also, one of the things, and I've mentioned it to some of the legislators, is that the negative interactions with individuals with law enforcement, in many cases, is where a person is in mental health crisis. And, you know, the first group that's brought to the scene often is law enforcement. And, you know, that can escalate. You know, the person who's in crisis may already be somewhat paranoid, or they just feel that they're not understanding all that's going on. They can't respond to orders. And, you know, that it sometimes leads to, you know, some of these incidents that people are concerned about. And I know training of law enforcement will help, but that is not their main job. And one thing they have to do is they have to protect their weapon. And so, you know, if we can get to the person before they reach that crisis stage, you know, to understand that that person is in a very difficult situation, they may not have that, you know, may be an imminent threat when the family, you know, understands that this person is not acting the way they typically do, or they're acting, you know, their actions are irrational. To catch them early might be, you know, that can be beneficial, and avoid those interactions that we have seen from time to time, where law enforcement comes into play and the person, you know, either has a weapon, or they're very difficult to restrain, or, you know, in some other case where it can be, you know, a fatal incident. So it's just, you know, trying to look for how we, you know, cut down on those, you know, that interaction as well. Okay. Well, thank you, sir. Appreciate your coming in and testifying, or not testifying, but giving a presentation. I think it's been helpful.
My great pleasure. Thank you all for your time.
Okay, thank you. Now I'll turn to you know, the public presentations or testimony. We have a few people who had signed up. Kent Alford, Systems Behavioral Health Director. Is Mr. Alford on the line? He may not be. I see a message saying that he did not join us. Okay. Aaron Farley, Community Wellness Manager, Calvert Health Medical Center. Aaron Farley. Aaron Farley is not on the line either. Maybe she'll come back. Katie Rouse, On My Own.
Hello, good afternoon.
Good afternoon.
Oh my gosh. Good afternoon,
Oh my
Lieutenant
gosh.
Governor. All
Okay,
good.
good afternoon.
Thank you, Lieutenant Governor, senators, delegates, commission members, and everyone watching at home. As a person who's used mental health services and a member of a family that's been impacted by mental illness and addiction, I really, from my heart, want to thank you for your commitment to improving our system of care and for this opportunity to speak. My name is Katie Rouse, and I'm the Executive Director of On Our Own of Maryland. And since the 1980s, our peer-run network has launched 23 community-based wellness and recovery centers across the state. At the last commission meeting, you all heard from Sharisa, who works at the center in Frederick. Many of our 6,000 plus members are not just living with a significant behavioral health issue, but thriving and using what they've learned to help others stay well too. I wanted to speak this evening because in the Commission's annual reports and recommendations, it seems like the goal of recovery is out of sight and so out of mind. The goal of services should not be in enforcing compliance, but in helping people get back to a self-directed life in the community with self-selected supports as quickly as possible. Stigma and feelings of powerlessness are already huge challenges for people who are on the edge of crisis, whether this is their first time or their fifth. But if our policies focus on danger, but not de-escalation, on resistance to treatment, but not trauma histories, and on deterioration, but not diversion, we risk bending the system toward producing isolating, coercive, and painful experiences that drive people away. But when we integrate peers, people with lived experience, as partners and providers, when we invest in a robust menu of recovery support services in the communities where people live, we reaffirm the dignity and agency, capacity for healing, and potential for recovery in every person. So in the Commission's third year of study, I want to ask you to please explore and invest in the wisdom of people with lived experiences to help shape our system so that it welcomes people in instead of pushes them away. Thank you so much for your time and for your listening.
I had muted. I didn't want to rustle papers while you were speaking. Thank you very much. No, that's a very good point. We do need to hear more from individuals who are recovering, who are living productive lives, because we tend to focus on, I don't know if it's best to say the extreme cases. And so, we don't want to be heavy-handed in trying to, address the extreme cases where there are people that know that they need assistance and they're ready to get it, and it needs to be done in a way that's compassionate and that has, as we talked about, even for the extreme cases, the wraparound services. And I think more and more, at least I'm seeing that there's more than just, the treatment. There's more than just intercepting at a certain point, but it's also those other services that allow them to live a productive life. So thank you for your time, and please, continue to stay, keep in contact with us as we go through this process. Okay. All right. Thank you. Scott Davis.
Yes, sir. Can you hear me okay?
Yes, I can. And see you.
Hey, sir. How are you? Lieutenant Governor and members of the committee, thanks. I appreciate y'all allowing the public to make comments on the stuff that's in front of us these days. I'm a police officer in the state of Maryland. I'm not representing my agency right now. I just didn't have enough time to clear that through the chief. But I can tell you, I wanted to throw this out, and I think that we need to support the fact of having statutory guidance as opposed to a regulation on a definition of dangerousness. I think that's very, very important. I'm glad I'm on the front line every day. I'm in hospital ERs daily. I work heavily, I'm heavily involved in our crisis intervention team in the department I work in. And I've been doing it for 18 years, about 28 years, about 27 years total law enforcement experience. So, I mean, the things we see on an everyday basis are pretty significant regarding mental health. And I don't know very many police officers out there that want to see people that are put into a forensic environment. Unfortunately, you know, in today's world, we often see more forensic cases than we really want to see out on the street. I can tell you from being in the ERs on an everyday basis, dangerousness is very subjective in nature. It could really vary from physician to social worker to clinician to police officer. It really does. And it's very difficult when you see family members present their loved ones in a hospital ER setting and try to get them needed services, and the family member refuses to sign in or refuses to get the treatment they need. You know, it's very difficult to compare that with parity. You know, I like to use the word disparity in a hospital ER because I don't think people with mental illness are treated as well as people would say an underlying heart condition or asthma or COPD or something in that type of somatic environment. So I think it's important for the legislation to kind of define what the dangerousness would be. Using a regulation, and I think the Treatment Advocacy Center said this very well, putting a regulation in place, I don't think it's going to be reviewed appropriately by every law enforcement agency in the state of Maryland. I think putting in the law, I think it'll be incorporated into our law class, and we'll be able to teach that to the academy recruits on an entry level as well as an ongoing in-service lateral, like a lateral type training that we do every day, similar to what continuing education credits do. So I just wanted to throw that out. I think it's important. Again, I mean, we just see so many disparities with the way that the individuals come and present to us. We're working a case right now. We've had to do, and we call them mercy arrests, and these are arrests where we get these people into treatment, and we have to do that by arresting them on simple things: urinating public, trespassing, those type of offenses. And unfortunately, when they get to a forensic environment, they get up to Springfield, they get to wherever they need to get restored. And usually when the statute of limitations is up for the offense, they're kicked back to the street. They are stabilized to a certain extent, but they get back out into the street and then they decompensate very quickly. We're dealing with an individual now that we've had to, arrest up to 5 times right now. And we're actually working with the BHA for the state of Maryland to try to get this individual some needed services. So I think people need to hear that from people that are on the ground and see this. The last thing we want to do as law enforcement, especially in this present environment, is we don't want to put people in jail for having a mental illness. It makes no sense to the majority of the officers out there. So I just want to kind of throw that out, let you know we are watching. We are kind of hoping that the latest legislation comes to fruition, and that maybe this could be defined in a more easier manner for everybody to be on the same keel, if that makes sense. Thank you.
No, thank you. That's very helpful. To hear from you, in terms of the challenges that you're facing and what you're seeing, and the subjective nature of the definitions. I don't know if you've contacted any, maybe your state senator or one of your delegates to let them know, how you feel about that piece of legislation and the need for a more clarity on that definition of danger, the danger standard. That probably is one step to take, but I appreciate your providing that information here. Does anyone have any questions for Mr. Davis?
I just have a question. Well, it's more of a statement with regards to changes to regulation versus changes to statute. I'm not sure where it was said that the plan was only to change the regulation. Our plan was to change the statute. We've never discussed changing just the regulations. So I'm not sure if that was a discussion someplace else, but I know in this meeting, I think we've been talking primarily about the statute, and certainly the work that the BHA has been doing. And what we're looking to do is to change the statute, not to change the regulations. Well, to change the statute.
I may have, raised that as an alternative if the statute doesn't go through. That one start could be, making it a regulatory, defining it in regulation. you know, and that doesn't go as far as doing the statute, as the officer stated, as Mr. Stanton had also mentioned. But if for whatever reason the legislature does not change it, you could start with the regulation and get that information out, because you can get it out to law enforcement, you can get it out to the hospital association and the physicians and psychiatrists, I guess.
Yeah, it probably is faster to get something changed in the statute than it is to get changed in the regulations at this point. So
I won't make any comments about our legislature. So, okay. Well, we'll see. We have a bill there, or there is a bill floating around. And so maybe if more people talk to their delegates and senators, maybe we can get it through. So that's good. Mary Ellen Moran. Is Miss Moran available? No. Okay. Evelyn Burton. I guess, the sun is shining. It's gotten above 40 degrees. People are in shorts and t-shirts. Still a little chilly, but I guess.
Okay, here I finally.
Oh, okay. There.
And
There you
actually,
are.
I see Mary Ellen Moran was talking on her phone there, but I couldn't.
Oh, okay. Miss
I don't
Moran,
know.
I'm sorry.
Figure out how to unmute.
Yeah, Miss Moran, I don't see you in my view. Let me see. I guess I can go further around. Oh, there I see Miss Moran. Yeah, you're on mute. I can't hear you, Miss Moran. I can see you. Is it on your computer? Is the mute on your computer?
You may want to hit *6 to unmute.
Or #6, I think it is.
#6.
#6 on the phone? Oh, on the computer. Okay.
She's on the phone.
On the phone. I think if you hit #6 on it, Miss Moran,
#6 on your phone.
Try *6.
I'm not sure why we see you on your computer and you're
Well,
trying to call in.
She has a video camera. It's not really coming.
Oh,
from
it's
the computer.
okay. It's not on
And then she calls on the phone for the audio.
Oh, I see.
I don't know. It's a hard system to navigate. And
Well, we'll go to Evelyn and Miss Moran, keep trying, and we'll start with Evelyn.
well, actually, I mean, I had talked to her before to try and figure out how she could do this, and we knew she might have problems. So she sent me her statement and asked me to read it, if that's okay, if she couldn't say it herself. Is that okay?
That's fine.
Okay. So, yeah, she's nodding her head.
I see something pop up. It says Miss Moran audio, but it has the phone canceled out. So for whatever reason, it's still not coming through. Okay, you can read the.
So she says, I have bipolar disorder and never have met the danger standard for involuntary commitment to a psychiatric hospital for my treatment of my serious mental illness. Current Maryland law provides that, among other things, an individual presents a danger to the life or safety of the individual or others. When I am stable, which is most of the time, I function very well. When I become hypermanic and then psychotic, my behavior is not threatening. It is weird. Also, I slip in and out of reality. I can't safely drive a car, prepare meals, or take proper care of myself and my son, 58 years old, who lives with me as a result of his serious mental illness. Also, I cannot make a rational and informed decision on any matter, including whether to seek treatment. The danger standard in Maryland needs to be changed to reflect the fact that many people do not meet the standard of being unable to provide even their basic needs like food, clothing, and shelter, health, or safety due to mental illness. Also, they can suffer substantial deterioration of judgment, reasoning, or ability to control their behavior and become unable to make a rational and informed decision as to whether to accept treatment. This happened to me when visiting my sister in Virginia. She called 911 and a crisis response team was sent. I don't recall much about the event, but I do remember a police officer talked me into going to the hospital. According to my sister, it took hours. I was in the hospital for 5 days, put on medication, and became stable and was discharged. I then was able to safely resume my activities of daily living. It is concerning that some people think it violates my civil rights to receive involuntary treatment in the circumstances mentioned previously. I disagree. The danger standard needs to be changed so I have the right to treatment when I need it. Thank you for the opportunity to give my verbal statement.
Let me ask this question, Evelyn. Because this occurred in Virginia, is it because Virginia's danger standard is different than Maryland? And Ms. Moran, are you okay? You don't know offhand.
No.
And you know, the fact that they were able to, I mean, I don't know if they considered that voluntary, and they just, you know, kept you there, you know, until they felt you were stable and you said that you were willing to leave. I guess they may have felt that was a voluntary.
From what she has told me in the past, she did agree to go there voluntarily with the police officer, but that when she arrived in the ER, she got more out of control, and so they did admit her as an involuntary patient. She doesn't remember exactly what she did in the ER, so it's hard to say what standard it met. But I think her main concern is that if she gets to the point where, you know, she can't make a rational decision on her treatment, she doesn't want to have to wait in that state and deteriorate further until she meets the Maryland standard.
Okay. Now, there are others who know this far better than I do, but I had once been told that you either have to have a psychiatrist, and at one point they said something like 2 psychiatrists, but at least a psychiatrist or possibly a police officer to bring you in to get an involuntary commitment. I don't know if that's true or not here in Maryland. Is that, anyone want to?
No, I mean, anybody can bring you, and you can go you can go there by yourself. Somebody can bring you in. The police.
But I'm saying involuntary, for it to be involuntary.
Right, so that's getting to the hospital. In terms of being certified involuntarily, it has to be a medical licensed professional. 2 physicians can do it, a physician and a psychiatrist can do it, a physician or a nurse practitioner can do it. It has to be 2 licensed professionals.
So it's 2 licensed professionals, not necessarily 2 psychiatrists, but 2 licensed professionals.
Okay.
Yeah, that I can see that being problematic. You know, because like you said, you have to get them to the facility or get the licensed professionals to the person. But I guess the police can bring them to the facility, or ambulatory care, ambulance can bring them to the facility. But then you have to have 2 people. You know, if you're at the hospital, you probably can get 2 people, but getting them there is the getting them there issue. Getting them in front of the professional. And if they're not aware of their situation, you know, if they don't understand that that they're in crisis, they don't understand what's going on, it's getting them to that location.
No, a social worker or a medical, you know, a licensed person, including social workers, can complete an emergency petition, which tells the police or the sheriff department, depending on what county you're in, that they can take them to the hospital to be assessed. And that's when you have to have the 2 people decide if they need to be admitted. So you can get them to the hospital with a social worker or a licensed person, or a family member can go before a judge and ask for an emergency petition that way too, which also sends the sheriff or the police to take the person to the hospital. So there are
But
ways.
but those situations, one, it's time, you know, and two, you've increased the strain within, say, a family or whoever seeking that emergency petition. You know, you really, you know, in some cases, you've created a very difficult situation with the person who may be a person that they trust. You know, even during their paranoia or their crisis, there's something that they still may trust this person who they've lived with all this time and can kind of see through it. They don't know why they trust them. But once you do this emergency petition standpoint, and it brings in an advocate for that person, it's just, it's a step. I understand due process, but it just seems to be a step that person, if they're in crisis and getting in front of a judge or filing this emergency petition, takes time. And
it does. And you're right, that is a concern. I have staff who say, you know, we're concerned about doing the emergency petition. We don't want to, you know, affect our relationship. I'll be honest, most of the time it turns out fine. Once the provider explains the situation and talks to the client about it, they understand. We're very clear in developing that therapeutic relationship that this is something we might have to do. So we're honest about it, but you know, it is a concern. However, most of the time it turns out fine, truly.
Well, but that's good in your case because you already have a person that understands that they have a challenge, that they're in front of you, they're there for a reason. But that family member who has an adult family member that either lives with them or doesn't live with them, that doesn't understand that they're having a problem, or they refuse to understand that they're having a problem. It's then when you get that emergency petition, it really creates, you know, a schism, or you know, there's a challenge that develops. So it's a little different in your setting because you already have some kind of a relationship. They're there for a reason. They come there. They know that they're getting help. But when you have that adult family member that doesn't quite understand, you know, that they're having, you know, some kind of problem. And think about that, you know, 22-year-old who develops, you know, schizophrenia comes on them at 22 years old, or some other psychosis that they don't think anything's wrong with them. They think everybody else has a problem. So that's my concern about that.
I don't think that there's anything that's been discussed here that would change that. Changing the criteria for involuntary commitment isn't going to change the process by which people are that we interact with people in the community who are having a behavioral health crisis, in terms of getting them into a place where medical professionals can evaluate them and make a determination as to what is the best course for this person, whether it's recommending inpatient hospitalization or connecting them to resources in the community. Now, certainly having a more robust crisis system would change that. So if you have more engagement with peers in the community or other providers in the community who can go to the person to have a healthier interaction and try to engage them to get the services that they need, whether they are able to assent for services or whether you have to go a more protective, coercive means route in order to get them the support that they need. But that is what will change the way that people interact with or connect to the behavioral healthcare system, not changing these standards.
Yeah. Okay. I guess so, particularly on the first time. But like what the officer was talking about, that revolving door of the same person coming in and out, and the crisis occurs at 3 o'clock in the morning on a Saturday morning or Thursday morning. It's law enforcement are the ones who respond. So I'm just trying to look for how we can get a person to, without it being, without it accelerating or, exacerbating the situation.
Right, without being traumatic. And I think it's really important that
Right.
We make sure we put enough resources into the community, because if we're not going to put people into treatment because we want them to be in the community, we want them to have options, we got to make sure we have enough treatment in the community for AOT. You know, you want this assisted outpatient treatment. Well, you better make sure there's enough services to treat these people. And that's often an issue as well.
And also, I'm sorry, Senator Hacker.
I'm sorry. Go ahead. I'll wait.
I was just going to say, and or a greater flexibility of the services that we currently have. You know, I think that we have a system of care that works best for people who have who are able to navigate. Even you know, within our very supportive network, you still have to have some measure of savvy to navigate the behavioral health system of care. And so having, you know, looking at other ways of allowing providers to work with a riskier to engage patient population, so that you're not so concerned about, well, I have to have somebody in the seat that I can bill for the service, so you can all, you know, so that you can actually take the time and make the risk as from a business perspective of engaging someone who might not want to engage, but that doesn't make it harder for you to subsist as a business owner, someone who's trying to provide a service. And there are very, very, very few services that will compensate you for care that you were not able to deliver, so that you can stay around long enough to try to deliver the care.
Yeah.
Right. And I was just going to add to that. I think we don't have enough opportunities for that crisis, that like what we would do in an emergency room in an outpatient setting or in a community rehab setting. There are some models around the country, and we're trying to work with that. But how you develop, as you talked about, if you have an ongoing relationship with an individual, there may be acute episodes, but there may be, as you said, Lieutenant Governor, some degree of people trust you for some reason. They know you're familiar for some reason, and how you're able to really work with that to get those services in a non-threatening kind of way, so you don't further traumatize the person. And I think that's what I know Dr. Jones has been working on, behavioral health has been working on. We just don't have enough providers, and hopefully we'll be able to get some more, because we're going to have a little bit more of this as we go through the pandemic.
Right. And maybe, you know, this is a different subject, but and it all comes to money, and I'll just throw money out there. But you know, it's in addition to the services, it's having the providers, you know, and so you know, how do we encourage more people to become providers? You know, either, you know, on the nurse practitioner, the psychiatrist, the social workers. How do we do that? It's again, a lot of it's resources, but a lot of it is also, you know, getting people to choose to go into these areas. Maybe COVID is one of those areas that people, you know, one of the things that people realize that we need our public health system to be more robust than what it is. And maybe that will encourage some, you know, person who's in a profession or is going to school to decide this is an area that they really want to go into.
Or we grow our own. I know I've gotten involved with a homeless shelter who are trying to deal with an overnight stay when people are out of control, but at the same time provide a little more like a month visit. And that's where I got involved in this other challenging case. And these folks who are running the shelter really know that there are behavioral health issues. So how do we put our triage team of professionals and then be able to support those people who may even be volunteers or unskilled folks coming into it, to be able to provide them the resources that they need to get them more engaged, because it becomes an entry into a delivery system. And people are curious and want to give back, and may have because of their own personal experiencing. I think that's where we wrap not only our services around the individuals who are impaired, but the individuals who want to help at the same time. And I think Dr. Jones is worked really well in providing a lot of resources for folks out there in promoting a very integrated and multi approach system of care to be able to meet the needs.
Yeah, and I think that also, you know, the peer recovery people, like what Ms. Rouse was talking about with, you know, On My Own, can be helpful in that area as well. That they not only are helping each other who are part of the organization, but can possibly, you know, help some others who are, you know, in a situation that could use someone just to talk to, just to talk to. We talked, you know, when we first started this thing, this commission, I believe I sent an article around about what they were doing in Zimbabwe, and they had this, you know, they called it community benches, where elders would sit on the bench and they basically would talk to people who were experiencing depression for the most part. And because culturally people respected elders, these were, you know, people who were trained in nursing or something of that nature, but they were retired and they just were there to listen to a person who is going through some kind of difficulty. And it's kind of a peer recovery aspect. And so sometimes it's just, you know, communities helping people, you know, and because in that country in particular, they had, you know, they had an extremely limited amount of people who were psychiatric trained. And so they thought, well, maybe we can utilize these, you know, these elders, you know, that are just friendly people who sit on a bench and wait for someone to come and just are able to provide advice and talk to them about, you know, the issues that they may be confronting. And it was more geared toward not the severely mentally ill, but more those who are minor depression or just feeling down. So. All right, well, I don't know if any of the previous people we called Mr. Alford or Farley, I don't think they were on. Is there anything else that anyone wants to talk about?
Good discussion.
Or just general discussion, yes.
So I'll jump in. I want to go back to Katie, and the reason for that, Katie, I have some comments and some questions. In Maryland, we have on our own, we have the Wellness Recovery Centers, or WRCs, and then I never remember the other acronym. Whether it's, you might remember it. But so there was an evolution of mental health centers for those that were in recovery or working on their mental health issues. And then there was the substance use programs. So two different titles. And many of the programs that we have in Maryland they're not called the same thing. So on our own isn't always an on our own, as an example. And for me, I find that whether it's the mental health or the substance use or those that are integrated like Howard County is, I think they're such critical sources for the continuum of care in recovery. And what frustrates me is I have to, fortunately, through BHA, I get a list that we can then share and disseminate. But if you're a family that has a loved one that you'd like to find a connection for them, where do they go? And that's the big challenge, I think, because we're always, in the work that I do, we're always looking at how does the family with problems find the source of the solution? And I think it's so important to consider the wellness centers or on your own, whatever they're called, that families can find. And right now I'm frustrated that that's really not an easy thing. So one question I have for you, Katie, in the On Our Own world, of the programs that are offered, how many of them do both the co-occurring mental health and substance use or don't?
Oh my goodness, thank you so much. And it's a pleasure to be speaking with you, and thank you for the question. So I think there's the recovery community centers, what you're talking about, that kind of that other acronym, is very much a, because our system wasn't always integrated, right? There, just like in everything else, there's kind of two streams of funding. So the On Our Own movement absolutely came out of folks who had experienced, for the most part, psychiatric hospitalization as that self-help support group, you know, on our own, based on this wonderful book by Judy Chamberlain about patient-run alternatives to traditional mental health services. So not all, just like all squares are rectangles, but not all rectangles are squares. You know, all of the centers in our network are independent nonprofits with, if they're affiliated with us, one of our standards is that you have a board that's at least 51% people with lived experience. So every center is really responsive to the needs of their community. For instance, on the Eastern Shore, we have Chesapeake Voyagers, which serves the whole Midshore region, or Lower Shore Friends, that serves the lower 3 counties. Other counties have their own On Our Own, Honor of Howard County, Honor of Carroll County. And then, for instance, in Western Maryland, we have the Office of Consumer Advocates, who run 3 different sites in the 3 westernmost counties. Every center is different, and some of them are able to use funding sources from various places, and so enhance their services. Our center in Dundalk absolutely runs a kind of a substance use focused recovery support center, as well as a mental health focused recovery support center. Other places like Carroll County, it's you know, have a lot of folks who are living with a co-occurring issue, and so there's not this kind of artificial siloing of one group versus another. So all of our centers have the ability to support people who are in a recovery journey, whatever that looks like. I think over time, each center has molded its particular menu of services and supports to respond to, you know, what people are coming in the door asking for help. That's the big point of peer support services. It's not a treatment plan or goals or something I'm telling you that you should do. It's, what do you want to do? How can I help you get there? And we do a lot of work related to, you know, filling out unemployment applications, applying for benefits, looking for jobs, accessing food, whether that be, you know, meals in the center or connecting with a food bank. So there's it's really kind of whatever you come in and ask for help with, we're going to find a pathway there. Your question about, you know, how do communities, you know, first timers find out about our network is a really good one. I think, you know, in full transparency, we have a great responsibility to promote what we're doing. The virtual world has really opened that up. People who maybe couldn't travel, especially in rural areas, couldn't travel to go to a center, but who can now sign on and do a virtual support group. I think the other critical piece is, when you have peers embedded in clinical services, peers are aware of the peer network, right? Folks who like know the pathways, know who to talk to, have relationships, can navigate that, just like community health workers in the somatic care world. So if we look at a systems level issue, I think it's all about integrating peers into our behavioral health workforce, because it's all about the relationships and lived experience of navigating, like Dr. Jones talked about, you know, a system that has a lot of acronyms and a lot of doors that don't open all the way or close every 90 days, and you have to kind of figure out how to get through. Does that answer your question enough?
Well, I totally understand the different funding streams and all of that reality. And I work a lot with peers. So I also think I appreciate the peer network. And I'm not convinced, Katie, and I would love to be wrong, that the peers typically know where to send, as a rule, know where to send everybody. I think there's some additional development possibility in peers as far as, because the system's changing. You know, the system in Maryland, fortunately, is expanding and changing. So I love the idea of the peers being the source. And then in a couple of different ways, we're working on making sure that that there's access, that the public knows that there's a peer person or a peer number or a peer email or whatever that you can tap into to find these resources. Because I think what you're talking about, the services, are critical. I mean, to the average person, maybe they don't sound that, you know, where to find food, transportation, but we know housing is an issue, transportation's an issue, you know, food, it just is. So I thank you for all you're doing. And I'm going to still work on getting the information out.
I think if I can quickly, certainly the peer community is not a monolith, just like any community, right? And just like some therapists we've gone to are great and we have a firm rapport, and some therapists we go to a couple of sessions and think this is not helpful to me. You are not helping me with the thing I am asking for. So yeah, there's going to be variety in every profession, right? Of what folks have. One of the great things in Maryland is that we do now have a certification program for peer recovery specialists. So there is a lot of training, national curriculum, local resource awareness. And my organization does a lot of that to connect peers with the trainings that help people develop their skills, right? Use their lived experience and develop very specific skills to provide peer support. So I put our website in the chat. It's onourownmd.org. And I would be delighted to connect with anyone in any community who'd like to learn more about what we do. Thank you.
Thanks, Katie.
Thank you.
And Barbara,
Katie, can I ask real quick, Katie, do you also have social media presence? Twitter?
We do. We have an Instagram handle and we have a Facebook page, and that's one of the areas, especially now that that everyone is looking for things virtually, that we're enhancing. So I'll put those in the chat as well and can share them for the minutes if that would be helpful.
Okay, thank you. Sorry, I interrupted somebody.
oh, I was just going to say, Barbara, we hopefully 211 Press 1 is a resource that people should be able to use, and they have a locator to identify resources in the various jurisdictions. And then the other thing would be for them to reach out to their local behavioral health authority, core service agency, or LAA. Well, in this instance, you're talking about a core service agency or LBHA. They would know the resources in their community best. So that would be and the peers certainly can use them as a resource, as well as the community using them as a resource.
Yep.
Okay.
If I could just add something in terms of the.
Please. Oh yeah, you didn't give your testimony.
Well,
you gave Ms. Moran's testimony.
That's okay, that's all right. I mean, I can do that some other time. I mean, mainly I was going to talk about how, when I compiled almost all the family testimony we've had over the years, or at least I put 30 of them together, of people that testified that the danger standard they felt was a barrier to getting their loved one into the hospital, either by a police officer or an emergency room physician who felt they didn't meet the danger standard, or a judge if they tried to get a petition, or even the ALJs. It was interesting that half of those people who did not get into the hospital ended up in the criminal justice system. I was surprised it was that high, but it was. And as far as changing the law, I think it will have a huge impact on getting people into treatment, because all of those people that were denied hospital admission, who ended up in the criminal justice system or homeless or committed suicide, under this law, the police and the ER physicians and the judges and everybody could get them into treatment earlier. And I also wanted to say, as far as the peer outreach, I'm a big fan of peer support. In fact, for my family member, I was such a big fan that I hired a peer to work 24 hours with him around the clock. But when someone is psychotic, and especially if they have Anasagnosia, they're not going to want to talk to a peer or anyone else about mental illness or getting treatment. In the end, my relative with this 24-hour peer, unfortunately, was not on the right meds, became totally psychotic, accused his peer of being a Nazi, and wanted nothing to do with him. So if somebody is somewhat stable and they're willing to talk to a peer, I think that's great, and it can help get them on the right track. But if they get to a point where they don't understand they're ill and they're afraid of everybody basically, you need to get them into a hospital to stabilize them so that they can work with the peer. That was about all.
Okay, well, thank you. I think we're coming to the end of our discussions. If anyone wants to provide any additional information to us, of course, they can go to, email us at mbh, mental behavioral health, mbh.commission@maryland.gov. Our next meeting will be May 11th. And we're, as you can probably tell, we're meeting every other month at this point. And so May 11th is our next scheduled meeting. And we'll send out more information. And I know we have the subcommittees are meeting and their information is on the website. So I want to say thank you to everyone for participating, and particularly those who provided public testimony and comment. Please be safe, and thank you again.
Thank you.
Thank you.
Thank you.
Have a good night.
Good night.
Good night.